So 3 million South Africans could be infected with the COVID-19 virus and 40,000 could die by the end of the year. Well, that's according to projections by modelers who made a presentation during a virtual briefing today. But the Health Minister, Dr. Zweli Mkhize, says South Africans can turn the tide of these projections by changing their social behaviour and taking responsibility for infection control. Joining us now via Skype is the chair of the COVID-19 Ministerial Advisory Committee, Professor Salim Abdool Karim. Prof, a very good evening to you. Thanks for joining us.
Good evening, Griselda. It's a great pleasure and a very warm evening to all of your viewers.
Thank you very much, Prof. So from one of the presentations earlier today, I did indicate in my intro there, the projections are that COVID deaths will go up to 40,000 by year end and infections up to 3 million. As the Ministerial Advisory Committee, what are the implications in terms of South Africa's existing plan to combat the spread of the coronavirus?
When we look at the current situation, we know that the epidemic is still at a very early stage. We had expected that the situation would have been a lot worse in early March, but we were able to avert that situation due to a range of interventions. We are now at a situation where, as we ease the conditions of the lockdown, and we will start increasing our movement, going to school and beginning to go to shops and to work, we can expect that the virus will start spreading a little faster. It's up to us, as has been very clearly explained. If we follow the rules of social distancing, if we maintain our hand sanitizing, we need not see that worst case scenario. We could have a much better situation. So you have a situation where the current projections look reasonable under a range of scenarios which do not suggest that we would become much more careful and much more conscientious about how we interact with our fellow colleagues. And if we do that properly, our situation could be a lot better.
Prof, I'm just looking at one of the tweets that came through here from Sianda Waltamda, and it points to my next question about, for example, model predictions in the United States changing several times. At first they predicted about 50,000, then moved to 74,000. Prof, we can make the best projections in the world, but others, including, for example, Professor Stephen Friedman, are arguing that those predictions will depend on the behaviour of South Africans, which you alluded to. Are you also looking at that as a critical aspect?
You're absolutely right. And when you look at, for example, in New York, when the first set of projections were done, they were done on the basis of existing behavior and were planned in a linear way. However, what did happen in New York is, as people began to see others getting ill, as they began to understand what was happening in the hospitals, they changed their behavior. They became much more conscientious about staying at home. They became much more conscientious about where they went, how they went. They became much more conscientious about keeping records of who they interacted with, so that if they were exposed, they could take the necessary precautions. So it is in our nature that we shall change. And that has occurred in many settings. I think for us, because we are in a situation that we explained that we were expecting a really devastating epidemic, and it didn't occur because we stayed at home, we are not clear about why are we staying at home now, because we don't have a big problem. But this problem is going to come when we stop staying at home and we're going to work. And we have to go to work. We have to begin to get our lives, because this virus is going to be with us for many months, if not years. So how we go back to work, how we go back to school is going to be key. And we do have prevention technologies. We do have prevention options that we can use. And all of those have been well described. If we just be conscientious about it, we can avoid the worst case scenarios.
Prof, I'll come back to some of the concerns that have been raised by some of those who are looking forward to engaging with you via social media this evening. But while we have seen the different provinces prepare for this peak, experts in the country are projecting that in the Western Cape, for example, the province could run out of ICU beds by the end of next month if the coronavirus continues on its current trajectory. What are the risks of that, and what's the plan to ensure that we don't run out of medical supplies?
So it's a very good point, and in fact, it's the central issue about what our national COVID-19 response is aiming to achieve. We refer to it as flattening the curve. So when we started our initial response against this virus, we had hoped that we would be able to contain it. But we were always concerned that containing this virus was going to be a major challenge. And that's for a range of biological reasons. The most common of those is that a fair amount of the spread occurs before somebody has symptoms and knows that they have the virus. So because of that, it's really a challenge to contain this virus. It's not anybody's fault. It's just the way the biology of the virus works. So if we look at the Western Cape and we look at the way in which this virus has been spreading, there are three things that have become apparent. The first is that there were little outbreaks of this infection, mainly in supermarkets and grocery stores, where people had to go during the lockdown. And so what happened is staff became infected, customers became infected, and the virus has now seeded in the general community. And it's become a challenge to really deal with it when it's in the general community because it becomes more diffuse. So what we're seeing now is that there are many more cases in the Western Cape. And because they're identifying cases, they're then going and testing the contacts of those cases and identifying more cases. So it will become a cascade. And that's what is going to happen in most of the country where we see dense populations. So that will be in our metros. We can expect to see a similar kind of picture. One can never predict how this is going to work out, but it's a reasonable expectation that we'll see that. And what that leads to, of course, is then more patients being admitted, and then we see more deaths. So it's the whole continuity of what we're likely to see.
All right.
Now, with regards to the patients in hospital, we can expect that we're going to see a situation where the demand for care and the available care will need to be balanced. And there will be a point at which that balance is lost. And so we need to ensure two things. One is we continue our efforts to keep the new cases down. And at the same time, we look at potential ways to collaborate with the private sector to establish additional beds where that's possible, so that we continually are trying to ensure that patients who need medical care get it, so we keep the number of deaths to a manageable level.
Prof, we did promise our viewers that we're going to bring them into this discussion as well. I want to take a look at two tweets. Just for now, I'll read them to you in just a moment. I think those will be brought up on our screen. The Challenger says, Doctor, what's your opinion on Gauteng as a densely populated province, having low infection rate relative to the Western Cape? What is Gauteng doing differently to keep the numbers low?
So I wish I could tell you I have the answer to that very complex question. For example, in many of our neighbors, they're just not seeing this epidemic yet. And we don't understand why. Some people say, well, they're just not testing. That's partially true, but that's not the whole truth. They're not seeing cases in the hospital. They're not seeing deaths. So we don't fully understand why this virus is spreading in some places and not in others. But what is becoming evident, and I've looked at the data, for example, from one hospital in Gauteng, because I said, is it true that actually there's a whole lot of cases in Gauteng that we just don't know about? And when we look at the testing of patients who are symptomatic at this hospital, we see a very low positivity rate. It's only about 1.4%. Yeah. So that tells me that we are testing a lot of people at that hospital. They don't have this virus. So it's not like you're testing the wrong people, because you're testing symptomatic people that meet the criteria for testing. So I think we can be reasonably confident, not totally confident, but reasonably confident that the levels of infection in Gauteng are at a much lower level than what we're seeing in the Western Cape. Now the challenge is to keep it that way. And as we go into winter, as it gets colder, as the interaction between people increases, we may see this dynamic changing. And so early identification of cases, if anybody's feeling sick, to get tested, to really, when you're told to quarantine, that you really follow the rules of quarantine. All of those are going to be important. And if we can do that, I think we have a good possibility that Gauteng may not follow exactly in the same way that we're seeing in the Western Cape.
All right, Prof, let's bring up another tweet as well. My colleagues are going to get that ready for us. Let's bring that up. Bridget Irish says, a question, can flies settling on surfaces spread the virus? Lots of questions, Prof.
So I haven't seen any data on that question, so I'm going to have to investigate that and come back to you. In terms of my understanding of the biology of this virus, it actually does not survive well on organic material. So it's quite likely that the virus will die quite quickly. But if you give me the opportunity, I'll get you a more accurate answer based on some evidence from a study.
Prof, let me bring in another one from Pule Makate here. He says, can the Honourable Professor please advise the entire National Coronavirus Command Council and their esteemed Minister of Education that teachers and learners aren't the doves that Noah sent out to the ark to check how safe it was after the storm? Please advise them accordingly, my Honourable Professor Karim. I think this is many concern that comes from parents whose children will be phased in, will be part of the first learners to be phased in grade 12 and grade 7. Can you give some assurance, Prof, to those parents who are sitting at home that the best is being done to ensure that their children are not, as some have said on my Twitter account, being used as guinea pigs at these particular institutions to test whether South Africa is winning in its efforts to fight the further spread of the coronavirus? Lots of concern there.
I really understand your concern. I'm a parent myself. I wouldn't want, our children to be in any kind of risk. But the reality of the situation is, what is it that we do know? The first is that children seem to be less susceptible to this virus. In other words, they have a slightly lower risk of getting infected when exposed. There was a study that was published this morning in the Journal of the American Medical Association which suggests that that might have to do with children having a lower number of receptors for the cells in the back of their throats. So there may be a range of biological reasons why children are less susceptible, but when they do become infected, they have a much more mild course of disease, often without any symptoms. And when they do get a severe form, it's a very rare occurrence. Now, we're beginning to see things and we're beginning to learn things about this disease that we didn't really know before. And it's almost on a daily basis. So we hear reports about children getting Kawasaki disease, children getting vasculitis, and so on. Those reports have come from very small numbers of children, from the thousands. You're only seeing 1 or 2 cases like that. And in all of those cases, those were conditions that were identified, and they were in a situation where we can now describe it as rare occurrences. So what does that mean for a parent sending their child to school? It means that your child has a low risk of acquiring this disease, and if your child does get infected, has a low risk of having any kind of severe disease. That risk is not zero. That risk, there is some risk that the virus may spread. We may see small outbreaks in school. That's not a cause for concern. When you see little outbreaks, we can deal with it. We can put in certain measures and control the spread of the virus. And we can ensure that most of the children will be able to go back to school without any difficulty. So the big issue is that this virus is here to stay. We will not be able to be protected from this virus, from a vaccine, for probably the next 12 to 18 months. We can't simply go and lock ourselves away for that period. We have to go back to school, we have to go back to work, and what we have to do is do that following the rules. And
Prof,
if we do that, we will have a low risk.
Prof, just forgive me there, I'm trying to get in as much as possible. I saw a report by the World Health Organization basically saying that South Africa is not ready to move to level 3. What are your comments on that, given that we heard the President say that there are some areas in the country that will move to level 3, and we increasingly see the numbers of infections go up and fatalities included?
So the decision about whether we go to level 3 or not is a complex decision made with many things taken into account, not just health. I can only comment on the health aspects. And if you look at currently within South Africa, our community transmission rates in much of the country are at reasonable levels. In the Western Cape, it's a different situation. But for much of the country, if you look at, for example, the Northern Cape or Limpopo, the situation there is quite different. So from a community transmission perspective, there is no reason for us not to go to level 3. However, there are many other considerations, and those will have to be taken into account to make a final decision.
Prof, South Africa, as the coronavirus vaccine is, of course, still being sought globally, what are we doing scientifically as a country to be part of this research, not only vaccine, but other remedies as well? I know that one of the tweets that came through here was asking why is what has come out of Madagascar, for example, not being taken seriously?
So South Africa is involved in many research projects. We are part of the World Health Organization studies. We are part of a range of other studies on both novel treatments and are looking at vaccines. But in addition to that, we also have to be looking at how research in our country contributes more to our understanding of what makes our interventions successful. We need to better understand how we can get locally made diagnostics. So there's actually quite a range of different research projects funded through the Department of Science and Innovation, funded through the Department of Health, that are all contributing in their own way to enabling us to deal better with this epidemic. With regard to the remedies that are being promoted in Madagascar, the particular medication that they've said is in the concoction is Artemisia, which is well known for having several medicinal effects, including an anti-malarial. It is not clear exactly what's in this tonic, and it's not clear what the evidence is that it works. So that's been requested, and we hope that that will be supplied to us, and we can then see to whether that evidence is sufficient. And I think we have to keep an open mind and look at the evidence and then make a decision.
All right, Prof, I'm hoping we can bring up another tweet there. Let's take a look at one that has come through. Let's have a look. That one is from Spiwe Collins. He says, good day. Any idea when the government will consider using the Madagascar so-called COVID-19 cure? I think the professor has touched on that just a little bit. Let's take a look at another one that has come through. And Sabulela says that the levels of infection seem to be rising drastically and our response seems to be less precautionary. Shouldn't we be channeling attention to funds to fields such as health rather than education, which can wait? Some health professionals still complain of lack of equipment. That's the question, Prof.
So let me just deal with the previous question very briefly. I would not call the Madagascan tonic a cure. There is no evidence that I have seen to call it a cure. I think it's better to talk about it as an experimental medication that needs to be proven. And when we've seen the evidence, we can then call it a treatment or a cure or anything. Until then, it would be incorrect to call it a cure. The second is, what should we be doing? I think that we've got to appreciate that we're going to have to learn to live with this virus. That we're going to have to find a way for us to get on with our lives and dealing with the threat that this virus poses. We can't continually avoid it. We have to confront it. And the way to do that is that we have a series of prevention tools that we can use. And there's a range of it, whether it's using a mask, whether it's sanitizing your hand, there's a range of them. So we have to be conscientious and do that. And if we do so, then we will be in a situation where we don't need to be concerned and we can mitigate our risk.
Yeah. Let's bring up one tweet before we move on to other questions. And now, Prof, this one from Musiwa says, at which age do comorbidities such as hypertension and diabetes become significant in terms of death rates caused by COVID-19?
So it seems that these comorbidities are quite important at pretty much all ages, but they play their biggest role in mortality in the elderly. But the approach we've taken is to be cautious. Anybody who has a condition that's in the list of comorbidities, and those are respiratory diseases, cardiovascular diseases, or immune deficiencies, as examples, we ask all of them to be particularly cautious and to take an approach where they will protect themselves even more from the virus than would normally be the case.
One from Joanne is coming up now, Prof. Let's take a look at that one. It says, Joanne says, what symptoms are taken into account during screening for referral for testing? It seems that only temperatures are checked, and by this result only, testing is recommended. The list of symptoms have increased, and I fear a lot of possibly infected people are not being tested. That's from Joanne.
Yeah, so we have a standard set of 6 symptoms that we look at, but the most common ones are the big 4, and that relates to fever, a cough, sore throat, and shortness of breath. If you have any one of those, then we would regard you as a person who is under suspect of having COVID-19. You need to have a test if you have one of those symptoms. That's part of the standard definition. We also recommend testing not just for those with symptoms, but for those who've been in contact with people who have COVID. So that's commonly healthcare workers, people who might have been exposed. But you have to, because the testing is not readily available, you have to have quite good evidence of that you've really been exposed, that you're not just concerned about it.
Prof, let's bring in one of the last tweets now. We're fast running out of time. You say, Naps says, good evening, Criselda. You're looking lovely tonight. Oh, thanks, Naps. You say, my question is, what is the pattern or commonality in the recoveries? I think that's a great question. What is the pattern or commonality in the recoveries that we've seen, Prof?
So the vast majority of our patients are recovering. I think the three factors which seem to be quite common in recovery is patients who are younger, patients without comorbidities, and patients who seek care early. So as we look at those features, we would expect anyway the vast majority to recover. And that we are seeing those patterns is reassuring, because we initially expected this based on what we were seeing from China. But we now have more evidence, and it's accumulating. And we'll begin to understand it better as we get more and more data, because we still have, at this point, compared to the data sets on China, we have a smaller number of recoveries.
Yeah.
I would think that besides age, which we know has always been an issue, for us the big challenge becomes the comorbidities, and that we have found to be a concern, particularly in the elderly.
Prof, I see there's so many tweets that are coming through here. I was about to read one from Dumi Letetsa, who was asking about, if the outbreaks at schools, with the outbreaks, if those outbreaks happen at schools, won't that jump back to parents or grandparents who are in guidance? I think that's one of the major concerns, but I'm going to move on from that because you did touch on it quite significantly. I have to ask you, Prof, we saw a scathing statement from the Health Minister addressing recent remarks made by Professor Glenda Gray on the lockdown. I mean, this is a challenging time, and there seems to be cracks amongst those we look up to during the COVID-19 fight. I'd like to ask you, is this dissent or is it a robust engagement amongst yourselves?
Well, I think if you have 51 academics, you must expect that we will have differences of opinion. In fact, it's those differences of opinion that is what makes the Ministerial Advisory Group strong. It is because we can robustly exchange ideas and come up at the end with some clarity about what are the options. And often in the case of dealing with COVID-19, there are many options. But through all of these deliberations, we need to ensure that we provide the best advice possible to the Minister of Health. And the public needs to be confident that we have considered the totality of the evidence that's available. We've considered many viewpoints. And out of that, we've tried to find the best for us to move forward.
But it certainly seems that Professor Gray did not have those. If you look at the statement that was issued by the Health Minister, Dr. Zweli Mkhize, it was basically versus what she said and the facts that he was responding to.
In the nature of the discussions that we have, we discuss many issues. And when we discuss them, we want to make sure that everybody has the facts available. And when we're discussing the facts, we then can look at the issue in a much more comprehensive way. But at the end, we want to make sure that the advice we give is based on sound information.
All right. And would you consider what the professor said as sound?
As we look at the opinions, a lot of what we do in this epidemic, it's unclear because the evidence is not well available. I'm not referring specifically to any comments she made, but when you look at, people say to me, well, don't you know that this is a cure or this is how you can stop this disease? I say to them, I need the evidence. Until then, it's hearsay. And we have to be careful that we don't promote information that is not factual. And so I think as we try to do that, we want to make sure that all of us are conveying as much as possible the factual information. That's important for all of us to know.
Prof, I'm afraid it's been 30 minutes and we really do appreciate your time here on The Full View. The chair of the COVID-19 Ministerial Advisory Committee, Professor Salim Abdool Karim, thanks indeed for joining us, and thanks on behalf of our viewers as well who've greatly participated in sending a lot of those questions. I hope I'll be able to forward some of these questions to you. There are many that are outstanding as well. Thanks to the viewers for participating in this conversation we're having on the program tonight. Let's take a recap once again of tonight's top stories.